My name is Neil Charnas. I'm the director of Florida State University's Institute for Successful Longevity. And we're really delighted to have Professor Bo Shi from University of Texas at Austin with us today. Sadly, unfortunately, it's still virtually rather than in person. And hence, sadly as well, there will not be a reception afterwards where you can all have hors d'oeuvres and drinks and meet with our speaker in person. But we're hoping the light is at the end of the tunnel and we'll be there in the fall semester. The topic of, or the title of our talk today is Aging in the Digital Health Era. And as we all know with COVID, a lot of us have had to move digitally. But first, let me just start and say a little bit for those unfamiliar with it about the Institute for Successful Longevity. We have a number of goals in our institute. One of them is to understand the mechanisms of age-associated disorders and functional and particularly cognitive declines. Our second is not just to be able to describe the nature of those types of changes, both positive and negative with age, but also to try to develop the best holistic interventions to counter those declines. And we do a lot of that intervention research here at Florida State. We also want to disseminate the knowledge, not just to our scientific peers, but also to the community, to aging adults, to their care partners. And that's what we're doing here today. And we think if we do a good enough job of that, we can cultivate the scientific, social, and political leadership on this issue that will engage the nation in this very important topic. Here's what we're not. We do not take older adults and turn them into young adults. That's not what our institute does. So let me just start off briefly. People ask, what's successful longevity? What's our institute all about? I think when an individual across their lifespan continues to be able to set, pursue, and hopefully reach their goals, when they can accomplish that, we think they can have a high quality of life. And it doesn't mean you have to be incredibly healthy in old age. It just means that, particularly with tools like technology tools, you're able to accomplish your goals. So we take two approaches. The first is what we call planning and prevention. We want to ensure people reach their senior years in the best possible physical and mental health. That involves avoiding damage, like I incurred this morning when a car hit me on my normal morning walk. Fortunately, not too much damage. We want you to be able to build up physical and cognitive reserve. Exercise, we know, is incredibly important, particularly aerobic exercise, mentally stimulating activities, all seem to be positive protective factors. However, we know things go wrong. And so when they do, we're interested in what types of interventions can restore function when impairments develop. So we're interested in processes like rehabilitation or compensating through particularly technological interventions that can augment failing abilities or in some cases substitute for them. So let me switch to our speaker today, Dr. Bo Shi. She has a really interesting background. Her original BA is in medicine at West China University of Medical Sciences in Chengdu. Then she proceeded on to a master's in psychology at Beijing University in Beijing. From there, she went on to do a Ph.D. in Sciences and Technology Studies from Rensselaer Polytechnic Institute in Troy, New York. She became an assistant professor at University of Maryland in the College of Information Studies, switched over to UT Austin in 2012 at the associate professor level, and then became a full professor, where she spends her time 3/4 of it in the School of Nursing and 1/4 in the School of Information. She's been very successful as a researcher. She's been funded by the National Institutes of Health, the National Science Foundation, and the Institute of Museum and Library Services on a variety of R01 and R21 and P30 grants. But she had a humble beginning. I first met her when she was a PhD student. Her husband was here in the iSchool at Florida State. And she visited me trying to understand a little more about aging research and the sorts of things we were doing. And on talking to her, I realized that she could potentially contribute to an existing project, the CREATE project, the Center for Research and Education on Aging and Technology Enhancement. And she got a student pilot project to collect data back in China. And it's part of our CREATE database to this day. Her research to date, she's generated over 90 publications on a variety of these topics. She's won awards from the Association for Information Science and Technology, ASSIST, and the SIG-Use Innovation Award in 2020, numerous state and university awards, and she became a fellow of the Gerontological Society of America in 2016. But she's famous for something else. Her children, she had identical triplets. You can see them there along with her son, who was born when they moved to Austin, Texas, appropriately named Austin. But Amy, Grace, Isabel are hopefully not going to break in on her discussion today. But let me turn it over now to Bo Shi. I'll stop sharing and she can take over and talk about aging in the digital health era.
Thank you, Neil. Thank you so much for the lovely introduction. I mean, it's been such a long journey, and I'm so fortunate to have met you so early in my career. I feel like all these years, Neil has really been a mentor to me. It's incredible to have this privilege to be able to collaborate with you and to have this opportunity here today to share with you what I have been doing lately. It's incredible, but I'm really very happy to see you today, especially. I mean, happy to see you every day, but especially today. Thank you for being here. And I think I know I met very few of you here. I'm going through but my presentation is going to be, let me pull out my presentation, but feel free to ask me at any point during my presentation. I'll be happy to take any questions you might have, because I think we have a good size. That's very good to be interactive. Can everybody hear okay with my sound effect? All right, okay, thank you. Okay, so I think Neil gave a great introduction already, so I'll skip over the self-introduction part, and I'll go straight to my to the outline of my talk today. First, I'll provide a quick overview of my research, the general areas, and then I'll talk about the three of the particular areas: electronic health information for lifelong learners, the eHIWQ program, which very much fits into what Neil was suggesting earlier, that we want to ensure successful longevity, and really learning is a big part of that. And I'll also talk about aging during the COVID-19 pandemic. The last part of my research that I'll cover today is going to focus on health information wants. And more recently, we've been working on providing tailored health information for caregivers of persons with Alzheimer's disease and its related dementias, ADRD. And finally, I would love to have some time to share with you the great experience I have had and lessons I have learned in conducting interdisciplinary research, which is really cool, but I'll get to that point. So next, overview of my research. My research really is at the intersection of these three particular areas. I study the older population, focusing on health, and in particular, the use of information technology or information and communication technology to help older adults get the information they want. And a key concept is e-health literacy, which refers to the ability to access, assess, and use digital information, digital health information, to make healthcare related decisions. So I have taken two particular approaches in terms of improving older adults' e-health literacy, because we know that older adults have lower health literacy and lower technology literacy compared with younger adults. So one approach is through lifelong learning, that we want to help people learn continuously throughout the life course. But also another approach, which I know Neil also has done great work, is focusing on how we could design the technology, the interface, so that it's actually age appropriate, it's senior friendly, so that people would not have to struggle in order to learn how to use the technology. And these two areas naturally emerge onto this what I call the eHIL program, Electronic Health Information for Lifelong Learners. But another key component of my work is health information wants. By this, I mean the types of information and decision-making participation that health consumers, including patients and their caregivers, would like to have, which often may be different from what healthcare providers think their patients need to have. So we are really talking about two different approaches. One approach is we think about what people want. It's a bottom-up approach versus what the healthcare providers think patients need to have in order to ensure compliance. And that's often different. So my approach has been really focusing on the health consumer side, focusing on health information wants. And I'll get to that part later as well. So that was a quick overview. Now, first, I'll go to the eHIL program. So we were fortunate. This really very much to Neil's credit, guided me through this process. I learned from Neil, first of all, what an R01, what an R03 grant was, and learning from the very beginning. And then for this project, we collaborated with public libraries, and we focused on providing different types of computer instructions to help people learn in a face-to-face setting, which, as you can already see, it's going to be in trouble during this pandemic, but we'll get there. And then building onto the success of our first program, we developed this eHIL C-squared program, which is adding the cognitive component to our existing e-health literacy training. The hopes was that we would be able to improve people's cognition in the process of helping them to learn about computers, because learning to use computers is supposed to be cognitively challenging. And if we can design the cognitive tasks right, then maybe we have some opportunities to improve both their e-health literacy and cognition. But our results, we are still waiting on we are at the very last bit of getting the manuscript out. the pandemic really has affected a lot of things. But so what we have learned was that our program was effective in terms of improving older adults' e-health literacy. However, the cognition aspect did not play out as well as we would have liked. And there are many reasons to it that for one, a lot of the cognitive exercise, like my collaborator, Julie Bug, she's an associate professor in the psychology department and the University of Washington and St. Louis. So the kind of intervention she's used to tends to occur in a research lab, versus when we provide the computer instructions for older adults, we tend to work in a field site, like a public library or a senior center, where we would have very little control in terms of the environment. Because as you can see in some of the pictures here, it's a wide open space, which is great in many ways, but it also means interruptions. So, and in some of the senior sites we were working at, they actually intentionally set up the computer labs in their kitchen area so people could come in and out, use a microwave and chat. So it's probably not the most ideal environment in terms of improving people's cognition, but we can get to that in more detail if there might be interest. So let me go through the projects first, and then we also developed another project building on my first the eHIL project. So for this one, it's a collaboration with my colleague Tom Ye, who is a computer scientist. He's in the computer science department at the University of Colorado and Boulder. So for this one, with Tom's computer science background, we were able to put the computer instructions on top of a real website, and that is different than watching a video. So the idea is that, well, typically when we look at a computer instruction class, people are facing multiple interfaces. So you have the instruction interface, and then you also have the application interface where people have to constantly move around the turn from the instruction interface is like, well, the first instruction was open a web browser, and then you move that instruction over to this other interface in order to play with it. And that adds cognitive burden to older adults when the cognition may already been challenged when we are trying to learn a new skill. So our, and then building onto the multimedia learning theory, we were hoping that by merging these two, because I mean, right now we are facing this attention split problem, but our hopes was that if we could put the instructions on top of a real website as an overlay, like what you see right now, click on the like a letter D. This is a instruction overlay on top of a real website. It's different from a video tutorial because oftentimes it's easier to take screenshots of the various websites, and then you put the instructions on top of screenshots. But we were really building the instructions on top of a real website. So our hopes was that, well, by merging the multiple interfaces, reducing it down to one interface, that would reduce cognitive burden on older adults so that they could free up cognitive abilities to focus on the learning aspect. And we did have some really interesting results. So this project, actually, we just wrapped up in April. I mean, we finished the data collection right before the pandemic, luckily, and that we've been doing the data entry, data cleaning, which is really fun because all the materials were stored in one place that we were not allowed to go back in. But anyway, so we do have some quick results that we are getting ready to submit, but essentially very quick results that both the on-top tutorial and the control worked. By the control, I mean, we used a paper-based tutorial. So instead of having the instructions projected on top of a real website, we handed over the conventional way of learning, like what you still have to work with multiple interfaces. So both of them actually worked, but the on-top tutorial actually worked even better, which is great because we were really afraid that we were facing a ceiling effect because the control was already so good. How are we going to get even better? It's very challenging. Maybe we should have chosen a sort of like not working so well control. But anyway, that's what we did. So in terms of e-health literacy, this was measured by the eHeals scale. It's essentially a self-efficacy measure where people say, well, I know where I can find high quality health information, the kinds of subjective measures. So for the on-top tutorial, the interaction between time and group was significant, and the on-top group had better performance in terms of improving e-health literacy, the self-efficacy part, and also satisfaction also approached the significance. It was like the p-value was 0.06. So we're like, well, it's very close. So the on-top tutorial worked better for our participants. And that was very encouraging. I'm actually developing a follow-up study with a colleague who just joined the School of Nursing here and UT Austin. And we are working on adapting this intervention to a Native American elder population because my colleague is a Native American and he's got a great interest in adapting this intervention to the Native American population. So that's in the pipeline. Now I talked about the eHeal program. Next, I'll go over aging during the COVID-19 pandemic, really what I have been learning from our older adults. Well, this started actually with back in February 2020. When things were going from bad to worse in China back in January 2020, I was really following the updates in China, and I got really really depressed with how things were going. So in February, I started just trying to jot down things that I have learned, and then we were able to. I was able to get wonderful collaborators who really acted very rapidly. We were able to do this opinion paper very quickly and got it published online March 13th, 2020, which was a very memorable date because that was a day when we woke up in the morning, we got this email from the president of UT Austin saying that his wife was diagnosed with COVID-19, the first case of the institution. And everybody was just panicking. But anyway, so that was when we got this paper out, and in which we really try to argue that global health crises are also information crisis. But this paper really focused on, from the information science perspective, focusing on what information science should be doing in terms of handling better future pandemics. Because a part of me is in the information science field. But after that, I felt the urge to continue with another one, which was we were able to get also great, wonderful collaborators, including you, here to focus more on the older population part, focusing specifically on the challenges that older adults are facing, which are quite different. Because what we realized was really older adults are really in triple jeopardy during COVID-19. For one, well, as we know, older adults are more likely to develop serious conditions, and the social isolation really, it's really not social isolation. The term was chosen wrong in the first place. It's really physical. Physical distancing that we should be talking about. It's not a social distancing we should be talking about. But as we practice the physical or social distancing, people are really at high risk of social isolation. And then also, as you recall early, like March, April of last year, people were switching to online shopping. And what we learned was in the early days that you could not, the windows of doing the online shopping was like they opens at midnight, and then it's gone. All the available spots are gone within 5 minutes. So how many older adults are going to stay up late at night? Well, I don't know. And you have done research in this area as well. I would love to hear as well. So people would have to stay up overnight and be quick and grab a spot. It was very challenging. So we realized that, well, in a pandemic like we're currently going through, older adults are less likely to have access to digital information or services like telehealth when we talk about. So these are the kinds of challenges older adults are going through. So building onto this paper, we were trying to argue that we needed to provide age-appropriate technology, but that's only a part of it. We must be sure to provide accompanying training and support. For example, high-speed internet access, perhaps it really should become a utility because it's really a basic human right, especially in a crisis like this. If you don't have high-speed internet access, you can't even compete for many of the online informational services that might potentially be available if you have this high-speed internet access. And then we also need to pay attention to the diversity of the older population. Of course, older adults are very diverse when we talk about even just age. A very different age, education, race, ethnicity, gender, and many other factors of computer experience. So how are we going to provide the necessary, just the right technology and training and support for people who are really in need of that? And then the importance of community partnerships. In the process of doing all this, I realized really there are some organizations. I mean, we know that there are a lot of organizations out there. They have been serving the older population for years, for decades. And but these organizations may or may not be in the best position to provide computer-related training and support for older adults. Meanwhile, maybe like for universities, we do have students, faculty who may be able to cover that part. So how we can develop really productive community partnership, that is really important. I can get into more details in terms of what I have done in my own work, if we have time for that. But let me also just cover this one pilot study we did last summer as a follow-up to the opinion paper that we did in terms of understanding older adults' needs during the COVID-19 pandemic. So we wanted to first understand what is going on during this pandemic. And then we did the data collection over the phone. Last summer, we had 200 older adults aging 65 to 92 years, average age about 74. So there's a lot we learned, but I'll just be able to cover very quickly a very small portion of what we learn in that study. As one example, we ask people, do you have a home computer or smart device? So if you just look at this pie chart, it's not too bad, right? Because 80% of the people say, yeah, I have, they have both a home computer and a smart device. And 9% of the people had either one. So that's not too bad. Only 5% of the people said they had neither a home computer or a smart device. If you just look at this picture, so yeah, only 5%, but really, if we dig deeper, we realize there are problems related to challenges related to technology access. For example, I'll give you some quotes. One person really tells us that, yeah, I have a smartphone, but it's not really working per se, and I don't really have the internet, and my phone connection is lousy. And then another person said, well, I don't really have the internet. And then I think a few of our other participants, they actually said that, well, yeah, I have the internet in the house. I turn it on twice a day. And we were like, what? You. So for people who are used to be having high-speed internet broadband, we are no longer used to the idea of what do you mean you turn it on and off? It's a foreign concept to many younger people, but that does exist still these days. And then challenges related to technology literacy. One quote, I think this person was having a good sense of humor, saying, well, it really depends on the person. And then someone else was coming in to show her how to use it, which is a risk, because you remember this was summer of 2020. It was really a risk to have someone coming into the house, but otherwise, how else are we going to do it? Because what we have learned is actually, I've been working with the local organizations here in the greater Austin area. We started sending tablet computers to people's homes, and then we work with them on the phone to help them set it up. Typically, it takes about 1 to 2 hours in order from the moment when people open the box to get out the tablet to the moment when they are actually set up on the internet. It can take 1 to 2 hours. That's really the level of resource we really would require in order to help older adults to have sufficient literacy and access and technical support. And then we had this other interesting item. We asked people, how comfortable are you using video chat services? This is when we were trying to understand how comfortable people would be with telehealth. So 49% said they're very comfortable, but we also have 38% of people who are somewhat comfortable and 13% not comfortable at all, really suggesting there's much room for improvement. So this is really a quick go through of what we learned in our project. We are in the process of also getting the results published, and I did not have the slides here, but in another manuscript, what we are trying to focus on, because we really have so much information. This other manuscript we are going to focus on is to report older adults' positive, mixed versus negative experiences during the pandemic. We started out this project thinking, well, older adults really are in need of digital access and support. So, and then when we got into the field, we realized, well, about 49% of our participants, they were actually having a positive experience. Now, there are multiple reasons too. Some people say, well, we're just coping well. The pandemic has not affected us at all. And then some people say, well, it's really not too bad compared with our peers, because I think I'm doing better than most of my peers. And then there's also the loner advantage. People who were used to be alone before the pandemic, now they feel like, what's the big deal? Yeah, it's a pandemic, but I wasn't going out anyway. I wasn't going to be socializing anyway, so that's okay. But there were also people had a very negative experience about the pandemic, and that's a different manuscript. If you might be interested, please do follow up with me. I'd be happy to share when that manuscript is out. And then we were able to get a rapid grant from the National Science Foundation to study trust in public health information among older versus younger Americans during COVID-19. So this is it's still ongoing. We got the grant officially May 2020, and then we just got a 1-year no-cost extension. So it's going to last until next April 20. 22. So we used the mixed methods data collection that we started with a survey. We recruited older adults from cloud resources like prime panels, which already you can see it, because these are older adults who are not only online, but also are familiar with the cloud services, such that they were able to sign up with the online survey companies to be in their database. And it's not a typical representative sample of the general older population, but that was what we were able to get at that time, which was very quick. We were able to collect the data from hundreds of people within just a few hours. That was incredible. And then based on the survey findings, we conducted follow-up interviews to better understand some of the key issues that we were trying to understand. Now we have completed the data collection for both the survey and the interview studies, and both of the manuscripts are currently in the pipeline. We are also, I think we started with the experiments. The third part of our NSF Rampant project was to develop, really try to understand what strategies would work for people to want to trust the information and to take actions, like what message, health communication messages could we give them that would help people want to be vaccinated. So for this one, we just started with the pilot experiment running with a batch of, I think we started with 20 participants last week, and then we're going to launch on a larger scale the experiments, I think next week. So it's in the pipeline, but okay, so that this are in the pipeline, so I will not be getting into too much of the results part, but if you might be interested in any of these parts, please do follow up with me. Now, that was the second aspect I was going to cover. The next one I'm going to cover is health information wants. I mentioned earlier, it's really this bottom-up approach, trying to understand. So we developed this health information wants questionnaire that included 2 subscales, information and decision-making, focusing on 2 dimensions, the information aspect and decision-making. And then under each scale, we have 7 subscales. We focus on information and the decision-making, participation in diagnosis, treatment. Well, I guess diagnosis, I should have corrected. It's like health condition specific, information specific about a health condition like diabetes. What are the causes, or the specific information about diabetes, and treatment, lab tests, self-care, psychosocial, and complementary and alternative medicine, and also healthcare providers. So a lot of these types of information, for example, information about a healthcare provider. A healthcare provider, when they see the patient, they may not think people would need to have information about their own credentials, right? But that's because it's already after people have already hopefully looked up and made the decision to go to a healthcare provider. Like and 1 year, my husband was getting a knee surgery. So as soon as we realized that he had a knee surgery, we went online and started looking for information about the surgeons, knee surgeons in the area, look for all the information and malpractice records, everything, and then come down with, okay, here, this is the top surgeon we want to see. And then we went to see the surgeon. So a lot of the information that we wanted to have and a lot of the decision making were already made before we went to see a provider. But this is so real. This is also very critically important from the health consumer's perspective. So that's we initially developed this instrument based on a grounded theory study of older adults, and then we tested the instrument, the questionnaire, validated among older Americans and younger Americans. It had excellent psychometrics. So, and then building onto that health information wants framework. Recently, I have been adapting the health information wants framework to the dementia caregivers population. And really the specific angle I get into the area is that information is power, and the technology is a key gateway to information and opportunities. So in terms of specific technology enabled new opportunities, in one project, we are we are hoping to develop this intervention where we could provide tailored information via intelligent voice assistants, such as Alexa. Oh, this is a picture I took with my, we have a Echo Dot, Amazon Echo Dot. It's like the lowest end product where you ask like, hey, Alexa, what day is today? Alexa, do I have a doctor's appointment today? And then you get the voice feedback. So we're hoping that we might be able to develop tailored feedback information to caregivers who are always very busy. So if you picture a scenario where a caregiver is in the middle of cooking a meal with her hands all messy, and then they may, it's like, okay, Alexa, just tell me, should I add cheese for that or not? And then the intelligent voice assistant could say, well, yeah, maybe not, and here's why. And that would be very useful. And then in a different project, what we are trying to do is to use machine learning algorithms to analyze social media posts by dementia caregivers to hopefully understand what types of information caregivers would want to have. So that's one piece of understanding, but based on the health information wants framework that we categorize and try to analyze and then train the machine to automatically learn how to accurately categorize the different posts. Meanwhile, we're also collecting information from credible organizations, information resources that have been developed for caregivers. And then we also categorize them and then try to match them. So if a caregiver say they put out, if we could detect from the social media post that this person really needs psychosocial support, then we could match them up with the specific information to tailor the information to give them that hopefully could make a difference. So we have done pilot study with Reddit, and we are also in the process of hoping to curate data from Twitter, which is challenging in some ways because, well, it's good in the sense that Twitter has a much larger database, but it's also challenging in the sense that Twitter tweets are short. And so how are you going to make sense out of 140 characters, or in terms of what the information people really want in order to make a difference? But it's also another interesting research idea where I try to understand what the different social media platforms carry different values when we do like big data type of data analysis. But we are in the early stages of these different projects. But I can also provide a quick view in terms of how we have adapted the health information wants framework to the Alzheimer's and its related dementias, the caregivers. So we still have, I think we went back and forth. We moved from 7 categories to 11, and then we decided to go back to 7, but with different names, different labels for each of the categories. Like for example, initially in our initial homework, we had self-care, but then we realized for dementia caregivers, really self-care should be broken down into 2 aspects. One is daily care for a patient at home, and then the other aspect is care for a caregiver, which is so critically important as well, because caregiving can be so stressful. And then we have to also include information about the care transition and coordination and the end of life. So, and then we had the keywords in order to train the machine to learn how to automatically categorize. Because, I mean, initially when we developed the framework, this was based on human experts deliberation that based on our analysis of maybe hundreds of social media posts. But if we want to scale up to maybe millions of social media posts, we have to get machine algorithms to do it. So this is another project I'm working on. And then, well, okay, this is in collaboration with Professor Da Qinghe, who's in the in computer and information science at Pittsburgh. And then what we were trying to promote is this expert machine co-development process, where we have like the health information wants framework as input. And then we have clinical knowledge. So we did actually have clinicians. I mean, I'm not a clinician, I'm a researcher, but we have clinicians on board who contribute, who really brings very important contributions to the team, that we have the framework and the clinical knowledge, and then the human experts look at a small set of data and then train the machine to learn how to do the categorization. And then the machine would give us feedback. It's actually very useful in the sense that the machine may return things to us that we, the human experts, initially might not have thought about, because a machine could come back and say, hey, in about 90% of the cases, when you categorize the X into this category, the word Y also appeared in 90% of the cases. Do you want to look at the Y more? And then we look at it, yeah, it does make sense. So, and then we would revise, and of course we revise the machine algorithm as well, so that it's a co-development process. And this was a pilot study that we were able to publish at the iConference this past, the conference took place in March, and it will be published in the proceedings. And based on this pilot study, we developed an R1 proposal currently under review, but we're also doing follow-up study on this project as well. So if you are interested, please also follow up with me. And now I'm looking at the time. How do I do? Okay, I'll try to speed up, because I have a colleague. So my colleague Myung Kim in the School of Nursing, she got a T32 grant, train predoctoral fellows about precision health. So she invited me to give a talk, and I'm looking at the precision health framework thinking, gee, this is a great way to organize my work as well. So I'll show you very quickly one definition I found from the CDC website in terms of how precision health is defined, and how information and technology could all be relevant, and when they apply to the kinds of work I have been working on, in terms of providing tailored information to caregivers. So I'll highlight the keywords here: your genes, behaviors, and environment, all are factors affecting our health. And then so what precision health needs to do is to measure these factors and to act on them. So interventions can be tailored and so that we can better predict, prevent, treat, and manage disease. So these are the 10 keywords that I thought were particularly interesting. And then for my work, these are the 10. For my work, certainly my focus has been on help people manage their chronic health conditions by providing tailored information. But in order to provide the tailored information, we need to measure people's preferences, for example, or other aspects, so that we can tailor the information. And in terms of measuring, we measure people's behaviors. We also measure their environment, because that's also important. But in my work so far, I have not been doing work on genes related work to tailor. But there are two particular aspects I would also be very interested in exploring further in my future work. One is predict, because this actually came up when I gave a talk in a different event. This was Alzheimer's Association's event. So people were asking, well, would you be able to predict who might be developing dementia based on the social media posts they make over the years? I'm like, yeah, that's great. We would love to do that. There are some constraints, because we would need to have really large amount of data and longitudinal data. So we currently don't have that, but it's certainly something I would be very interested in doing. And it's possible if we have the resource that we could build a way to have that much data for analysis. And then we need to get people to act onto the information that we provide them. I'm well aware that by providing information per se may or may not make a difference ultimately, because if people can have the information but still don't act on it, that may still not make a difference. But I want to do that. So this is the two particular aspects I would be very interested in working on in my research next. But okay, so that's quick answer. Interdisciplinary collaborations. Okay, I'll try to wrap up very quickly so that we have some time for Q&A. Now, I talked about my research being at the intersection of these three circles: older adults, health, and information technology. In my research, in the projects I have talked about, we really have had the collaborators coming from the social and behavioral science part and the clinicians. Also, we have computer scientists. By computer scientists, I include people who are trained PhDs in computer science, but now working in like a school of information or working on informatics related work. We really need interdisciplinary collaboration from these different areas in order to come together to find ways where technology can help make a difference. Now, I'll share also with you, interdisciplinary collaboration is key in just about all of the research I have been working on. In fact, all of the research I have been talking through, we had collaborations with folks in cognitive psychology, computer science, informatics, medicine, all these different areas. But here, so really interdisciplinary collaboration is key. And then I put in small font. I hope you understand it's supposed to be a joke. It's like when we buy those products, we get flashy big letters saying, oh, this product is awesome, get this one. And then there's a small font saying, but watch out, don't take more than 1 pill a day. So doing interdisciplinary collaboration really can be really fun, especially the first, I would say, 6 to 12 months, where we could really be shocked by the differences in the different disciplines. But I'll try to provide some examples. So in the health sciences versus the information science, how people use different terms to refer to the same thing, or use the same word, but or use different terms to refer to the same thing. So like, for example, in the health sciences, people commonly talk about patient education, and then CBPR, community-based participatory research. We also see that in the health sciences, people's professional labels are typically based on a specific disease or health condition. It's like, well, I'm a cancer researcher, I'm a diabetes researcher, I'm some other health condition. But from the health science or health informatics perspective, we don't talk about patient education. We talk about understanding health consumers' information behaviors. But that is really a foundation for providing the information to help people learn better. In order to provide a better patient education, we need to first understand people's information behaviors. Where do people find information? Which information do they trust or not trust? So that we can, or what information would be easier for people to understand. CBPR really, it's very much in the same spirit as what information science folks call participatory design. And my favorite part is informatics tools really can be used with most, if not all, disease or health conditions. So in the years I have been in the health sciences, I have been able to collaborate with people in various health conditions, because it really does not matter. I don't label myself as a cancer researcher or diabetes researcher or something else, or mental health researcher. The health informatics tools really can be used across the different traditional healthcare disciplines or subfields. So another example in terms of developing technology-based interventions. So this was we did a literature review on artificial intelligence for caregivers. What we learned was that, well, using AI to assist activities of daily living, really targeting a very limited number of specific activities. Like some people could, there are groups of researchers spending 10 years, more than 10 years of their research, just to understand how to get AI to help with hand washing, how to help a patient wash their hands by using artificial intelligence. That has taken more than 10 years of the research. So we are really at a very early stage. Exploratory, qualitative, small sample, theoretical, lacking empirical data from human subjects. Missing key pieces of information. So PRISMA, this is preferred reporting items for systematic reviews and meta-analysis. So it's like there are specific items, specific pieces of information that we are supposed to extract from the published work so that we can do a systematic analysis. And I was shocked that a lot of the studies that we found, they did not even report their sample size. or their participants' demographics. Some studies, they basically go like, oh, we tested our prototype on our graduate students and they liked it. No way, how many students did you test? All those key pieces of information were missing, which is really problematic from a point of view of trying to do systematic review, but also we got mixed results. Some people say, well, the prototype was fine, but others had negative responses. There was a little overlap between the health sciences and the CS and computer science and engineering databases. So really, research is still in the stage of technology development, far from ripe for clinical assessment, which just means more opportunities for interdisciplinary collaborations. I wish I could have more time, but let me very quickly just go through. Okay, always I get this question, will the generational digital divide disappear on its own? In the interest of time, and also because I realize this is an institute for successful longevity, so the audience, likely you already have thought about this and you know the answer already. My answer has always been no. But just to make it brief, as we age, so is technology. Technology actually ages at a much faster rate. So unless we really take interventions, unless we specifically really take steps to continue our lifelong learning and to have age-appropriate technology design, unless we do it right, the generational digital divide will always exist, unfortunately, but it can be changed. All right, before I wrap up, I'm putting a plug. So I'm actually organizing this special issue. If any of you might be interested, please do. The initial manuscript proposal, it's like no more than 1,000 words. Would love to see more contributions from FSU. Anyway, so that's a quick run through and I will stop here. Thank you so much for your time. I welcome any questions.
Thank you so much, Bo. That was a wonderful tour of a very large set of research studies. Certainly enjoyed it. Let's open things up for some questions now because we're getting a little late. If you have a question, you can either put it into chat if you don't want to say it in person, or you can unmute yourself and then ask your questions that way. So feel free to unmute yourself or let us know we can unmute you. Ibukun?
Thank you so much, Dr. Boyi, for the talk. That was really very engaging and informative. So I have two questions and then you answer the first one towards the end. So I wanted to ask about the distinction between precision health, personalized approaches to healthcare, and what you are doing. And then you explained that it's more towards precision health, which I was thinking, but it also looks like personalized approaches to care. So I don't know if you still want to explain a little bit there. Do you understand my question?
So the question is, what's the relationship between the work I do versus precision health and personalized health?
Personalized health, or maybe some people call it personalized medicine or personalized approaches to care. And then there's precision health. Sometimes there's a blur, you know.
Yeah. Thank you for the question. There are different terms being used, and sometimes we may be using different terms to refer to the same thing, or vice versa. But I actually had quite a good discussions with one of my colleagues early on in terms of tailored intervention versus a personalized intervention, and it's ultimately we agree that they are probably the same. And then in terms of personalized medicine, I would like to think that it's a part of precision health, but precision health is broader than just the medicine. And you realize I use the term like health informatics. I try not to use the phrase medical informatics, because when we talk about medicine, it's like a specific field, like precision medicine, versus when we talk about precision health, it includes fields like nursing, for example, and many other fields like pharmacy, social work, and these other fields are not considered medicine per se, but we are so relevant. Like, so I like to think precision health is a broader term that includes personalized medicine, includes precision medicine, but broader.
Okay, thank you for that. So I was also thinking about the barriers that if you might want to talk a little bit about barriers you may have experienced while trying to do some work on the use of consumer health research, consumer health information related research using social media platforms or any kind of other platforms. Pre-COVID, there were some restrictions with getting data sometimes. Sometimes it wasn't clear which platform you could easily use their data. Sometimes the question is who owns the data. Once it's on Twitter, who owns the data? So some of your experiences might help educate some of us who are trying to do such a research on overcoming some of those barriers. Yeah.
We actually we went through serious IRB application process because I wanted to make sure that everything is really on paper, on the record, everything is clear. But I think with some of the databases, the platforms we are using, we went through IRB and then we told them what we were going to do, and IRB came back and said, well, if the information is truly publicly available out there, then you do not need IRB. But still, we needed IRB to tell us that, because the decision should be made by IRB to say, you do not need our approval. So I think, I don't remember exactly which of the databases, but I think it might be Reddit. The data is just really freely publicly available out there, and people know that. So we could use it. And then there's some other, like a Twitter, you would need to sign up to have like an institutional researcher account.
Okay.
And you would be able to have free access. But because I think the process requires, I mean, frankly, anyone can sign up for an institutional account that you can have access to it, but still we went through the very serious process with IRB clearance. And also in cases where if we might need to get approval from the social media platform, like Facebook has a more strict policy, then we would need to talk with Facebook administrators and also the group administrators. We have not been using Facebook up to this point. So and also when we do report the data, we want to be really careful to remove all personally identifiable information, which is tricky in the sense that, it's actually a good question for discussion, because if we include any quotes in our publications, even if we don't report the person's identity, people just search the quote on the internet, they can find out who the person on which social media platform, on which day they made this comment. And they may, depending on the platforms, the profile information, people may even be able to know where you live. It's very tricky. So far, we have not reported any direct quotes in our publications. So, but if we come down to that point, I suppose it will require some discussion with our IRB.
Thank you so much, Dr. Bui. Thank you. Yeah.
Thank you for your questions. Great.
Other questions? We're starting at a little short of time, but perhaps Bo will stay on for a few more minutes.
Neil,
I can do that. Yeah.
Neil.
Yeah.
I do have a question as just an individual. When do you think the like the pre-science health, the holistic help would be available through either managed care or other providers, so individuals could use it to determine how to self-manage your own care? Because this is something that as we get older, increasingly we're having to do. At what point is it going to be more generally available?
Thanks, Marilyn. Bo, you want to look in your crystal ball and make some predictions?
It's going to be really tricky. In my health information wants framework, we did try to incorporate from the patients, from the health consumers perspective, what kinds of information people would want to have, like complementary and alternative medicine type of information. But if we are going to change the whole system, I'm not very optimistic.
All right, because I'm finding that family practitioners are not doing that, and we're left to our own resources, but we don't know how to measure the inputs. If you have two different problems, you're not sure how to balance that. along with your general health, diets, and rehab, or whatever it is. And a program like that would be very helpful to consumers, because we are, we're really in an area where we don't know what we're doing.
Yeah, that's a great point, especially for the older population. People tend to be managing multiple chronic conditions, and there could be potential drug interactions, or could be conflicting demands. It's very tricky, but I'm just hoping that by taking a more patient-driven approach, that we may be able to develop technologies that are more geared towards the health consumers' needs and preferences, instead of what the healthcare system thinks patients would need to have. But really, we do have a long way to go. I think probably starting early on in terms of getting the designers to think about how technology should be designed to meet the needs of health consumers, like the challenges you were just describing, that would be a good start.
Well, it's very encouraging what you're doing, but it would be nice to get something like that in our hands so we can have a successful longevity.
Yeah.
That's a great point, Marilyn. Thanks. Other questions?
Yes, this is Pat Hogan. And
Hey,
my question would be, in the mention that Dr. Boshi said about an objective of building both physical and cognitive reserve, how have you developed those educational interventions, and are you measuring them?
Yes, we do. We definitely, we measure them pre-post the intervention, and then compare the differences. So I think one project I mentioned earlier, our eHIWQ project, where we were trying to improve e-health literacy and cognition at the same time. The cognitive abilities, I think we included in the exercise, the cognitive exercise was supposed to improve retrospective and prospective memory. And then we did have measures for that. And then for the e-health literacy, we measure both subjective and objective measures. The subjective measures, we measure basically people's self-efficacy about their own e-health literacy skills, like I know where to find high quality information, that kind of subjective measure. But we also have objective measures, like we give people tasks. Well, you go to the web and find the information about the nearest place where you can get a flu shot, or like give people a task, a scenario, like one of your best friends was just being diagnosed with breast cancer. You want to find the information for her, and you could go to the internet and find three treatments that might be of relevance to her. And then we assess whether or not people were able to actually accomplish those tasks as a measure of their e-health literacy. So yes, we do measure them before and after the intervention. And I think in our R01 study, we actually did a follow-up. It was a 3-month follow-up. So we had the 3 data collection points. But for the R21 study, we were able to only do pre and post. There was no follow-up, because R21 studies only really for 2 years, very brief.
In addition to the telephone instruction that you do you do in-person training and assistance?
Oh, yeah. The kinds of interventions I talked about, they were all in person. They were all pre-pandemic. So those were the kinds of studies we were doing in collaboration with public libraries and senior centers and senior living facilities, where I would train and send out my research assistants to these various sites. And then we have partnership with these local organizations where they allow us to use their facilities. Actually, they really were very much welcoming our presence, because that's like one of the programs they could provide to their customers. So we use the facilities computer lab and their internet access to provide the instructions on site.
Thank you.
Okay, I think we're going to wrap up. I'd love to invite you all to the reception afterwards, but sadly, not an opportunity to do that this time. We are hoping by the time of the fall, if everybody's got their shots, their COVID vaccines, that we can resume having in-person meetings again. And let me again thank Bo Shi for a wonderful
Thank you.
presentation.
Thank you.
Thank you all for joining us today. Hope you're all doing well. Stay safe. And we'll see you hopefully in the fall. Thanks again for coming today.
Thank you, Neil. Take care, and thank you, everyone. Take care.